I'm Kevin Miner, a faculty member in the School of Justice Studies at Eastern Kentucky University. Most people understand that jails and prisons are fertile spaces for the COVID-19 virus. Fewer people probably realize the magnitude of the problem or the combination of actions that are necessary to address it. Public health and public education coincide with one another. So the purpose of this educational brief is to provide information about these subjects. Now, the most recent data from the United States Justice Department show that there were over 1.4 million adults in state and federal prisons at the end of 2019. There were almost 740,000 people in jail at mid-year 2018. There are also thousands of correctional staff members working in these facilities. The Marshall Project has tracked COVID cases since March 2020. By October 2020, there were almost 153,000 positive prisoner cases and about 34,200 staff cases. There had been almost 1,300 prisoner deaths and at least 86 staff deaths. There have also been thousands of positive cases among persons incarcerated and working in jails, and that includes several well-publicized outbreaks. The Equal Justice Initiative estimates that the viral infection rate among incarcerated populations is 5 times the infection rate in the U.S. overall. When confronted with a potentially lethal airborne virus that readily spreads from person to person, jails and prisons relinquish their typical out-of-sight and out-of-mind status. The reality is that these facilities are part of the larger communities where they're located, and that the threat of viral spread runs from inside institutions outward to the community, and also the other direction from the outside inward. After more than 40 years of mass incarceration in American penology, many jails and prisons are dangerously overcrowded and densely populated, significantly more so than hospitals and nursing homes. Density is especially high in the large number of open or barrack-style housing units that we find in America's prisons and jails. The lengthy sentences characteristic of mass incarceration have resulted in an aging incarcerated population that is at escalated risk of health issues. The population consists disproportionately of individuals with pre-existing medical problems, together with a history of high-risk health activities and subpar or neglected health care. Safe distancing is frequently unrealistic in prisons and jails. Ventilation systems are often faulty. Surface contamination is typically rampant. Disinfecting supplies are limited and might even be considered contraband. Protective gear like masks, face shields, and gloves can be in precious short supply in these places and may also be considered contraband. Testing is likely to be erratic or non-existent, and logistical challenges associated with contact tracing are exacerbated in prison and jail environments. Plus, it's impossible to overemphasize the fact that numerous jail and prison systems faced serious inadequacies and crises, really, in correctional healthcare service provision and funding before the pandemic ever began. These realities are not lost on people who have to live and work in jails and prisons. It's little wonder that large numbers of prisoners and staff experience continual angst over infection and illness. And collective angst over personal health and safety will only further elevate the usual high stress and volatility levels of these environments, increasing the chances of serious disturbances occurring. So, without effective action, prison and jail environments of the pandemic era are really perfect storms for preventable sickness and deaths among prisoners and staff, higher than normal levels of institutional disturbances, time-consuming and expensive lawsuits coming from both prisoners and staff that will span many years to come in the future, and in so doing will detract from needed improvements getting made later, as well as higher than normally high levels of staff demoralization, turnover, and staffing shortages. Now, two standard go-tos for jail and prison problems are the lockdown, either locking down the entire facility or major portions of it, and secondly, segregation of select prisoners. But these are at best stopgap measures that may or may not help mitigate viral outbreaks. Applied as longer-term fixes, lockdowns and segregation provide a false sense of viral control and much potential to exacerbate tension and turmoil among prisoners and staff members. So, in an article titled Jails, Prisons, and the COVID-19 Virus, which appeared in Correctional Law Reporter in 2020, Schwartz and Venters discuss 7 viable alternatives to relying on lockdowns and segregation to control COVID-19 in correctional facilities. The first measure, and really a foundation for the rest of them to work well, is reducing facility population sizes to manageable levels. Now, this can be pursued through accelerated release policies, prisoner transfers that are meant to make optimal use of safe distancing in available spaces in the prison or jail system, and sensible sentencing decisions in courts that would avoid or shorten incarceration to the extent feasible. Schwartz and Venters recommend population reduction goals of 25 to 50% for most facilities. Now, that's a tall order, but anything less is likely to be inadequate. The second measure is to establish separate dedicated housing units for temporarily housing COVID positive prisoners, as well as separate units for those who require 2-week quarantine and close medical monitoring during that quarantine. The third involves infection control measures like increasing visitation alternatives through phone and computer technology, sufficient availability of protective gear, disinfectant and hygiene supplies, and testing, combined with mandates that these things that I just mentioned actually be regularly used. Elimination of large, dense gatherings in spaces like dining halls and rec or programming areas, and regular symptom monitoring, for example, temperature checks. Symptom monitoring has to include persons entering and exiting facilities. The fourth measure is frequent, proactive, and honest communication among staff, especially between administrators and line staff. The fifth measure just extends the fourth one to include communication of that nature with prisoners. All communication needs to be two-way, with individuals who occupy subordinate roles being free to ask questions and voice their concerns without having to worry about adverse repercussions. Communication is really essential. If it's absent or if it's flawed, rumors and misinformation will abound. People will just fill in the blanks. The sixth measure is to expand mental health service provision and target more of this specifically around virus issues. More prisoners should receive mental health checks and services more frequently. The seventh thing is preparation for and response to emergencies, with the goal of devising and implementing an effective written pandemic emergency plan. Now, this may be accelerated by modifying an existing emergency or disturbance plan or creating an entirely new one. Regardless, the plan has to provide for timely identification of people in need of more advanced medical attention than what can be provided on site at the facility, and also for timely transport of such persons to a healthcare center. Now, to Schwartz and Venters' list, we can add the importance of ongoing, substantively valid, and regularly updated virus education and training efforts that are geared towards staff, prisoners and members of the public alike. There are then clearly other and better options than over or exclusive reliance on lockdowns and segregation. Ultimately, prison and jail staff, prisoners, and the public all share a common interest of sustaining health and safety during the COVID-19 pandemic. Viral infection rates among incarcerated populations in the United States are nothing less than a humanitarian crisis.